Thank you, sir. Good evening. Good evening to all. Thank you, sir, for that warm introduction. Thank you, organizers, for this opportunity. My slides are visible, isn't it?
Yes, yes.
I will take it as a yes. Yeah.
Yes,
so,
sir.
I'm given 20 minutes to discuss the maintenance therapy in the frontline management of ovarian cancer. This is the brief outline discussion. So I would start with the problem statement, go on to the history of maintenance therapy in ovarian cancers. What is the bevacizumab use and how it has transformed over a period of 2 decades. And we'll also look into the molecular subgroups of ovarian cancer that are evolving and the role of PARP inhibitors in the frontline maintenance strategies, and I have some concluding messages in the end. So this is the problem statement. There appears to be a requirement of significant unmet need. Basically, we need to improve the outcomes of our ovarian cancer patients. Because of lack of screening technologies, lack of availability of information, most of these patients are diagnosed in a much more advanced stage. Nearly 3/4 of our patients are diagnosed in the stage 3 and stage 4. Because of that, the frontline platinum-based chemotherapy, bevacizumab maintenance, these all result in a median progression survival of around 10 to 18 months. And it is expected that nearly 70% of our patients, unfortunately, are going to relapse within the next 3 years after the frontline treatment. So which makes the 5-year overall survival very dismal at 38%. So there is definitely a significant need for better frontline treatments to improve the outcomes for women with ovarian cancers. So this is how the natural history of the ovarian cancer patients goes. After initial PFS of around 10 to 18 months, with subsequent relapses, the PFS drops down by almost nearly 30 to 40%, and ultimately culminating in a possible bowel obstruction, bowel failure, and potential death. So this is how the history of maintenance therapy has evolved in the advanced ovarian cancers. It all started in 2003 with the application of weekly paclitaxel as a maintenance strategy post-platinum chemotherapy. This was a GOG 0178 clinical trial that was showing a detrimental effect of using a maintenance chemotherapy. So it was fallen out of favor. Several other clinical trials have done with the introduction of oral chemotherapy, etoposide, etc. And a meta-analysis has clearly shown that maintenance chemotherapy is going to increase the toxicities without any meaningful improvement in the PFS or overall survival. Then came the European as well as the North American clinical trials of GOG 218 and ICON-7 that established to an extent bevacizumab as a frontline maintenance strategy concurrent with chemotherapy and as well as maintenance that had shown a modest improvement in the PFS, but only overall survival improvement in a very subset of patients with high risk of recurrence. Then we have a plethora of approvals based upon the the PARP inhibitor in the second line setting as well as maintenance in the recurrent setting. Then we have the SOLO-1 clinical trial Prima, and we are having the latest mono-ethina, Methina mono. We are going to discuss in subsequent slides. So the maintenance therapy has evolved over a period of 2 decades. Prior to the PARP inhibitors, this is how the optimal sequencing happened in the frontline treatment options. We have the first decision making of whether the patient should go for NACT or primary debulking. Once the decision is made, patient can be applied with platinum combination chemotherapy in combination with bevacizumab. This is the data that is coming from the ICON-7 and GOG 218. There are some controversies regarding to the preferred dose of bevacizumab, number of cycles of bevacizumab, because both these clinical trials had a varying dosing regimen as well as the varying number of cycles that we will come to in the next subsequent slides. So this is how the bevacizumab is. It has only shown a modest benefit in the randomized clinical trials in the frontline setting. Both the GOG 218 and ICON-7 recommend the use of bevacizumab with chemotherapy, concurrent with chemotherapy, as well as a maintenance for select group of patients with highest risk of recurrence. These include patients who are stage 4 or suboptimal equals stage 3, or those patients who are having ascites and pleural effusion. And subsequent trials have shown that maintenance angiogenesis inhibition with actually pazopanib or nintedanib after the completion of chemotherapy does improve some PFS compared to surveillance alone. There has been no demonstrable improvement in the overall survival. So this is a GOG 0218 study schema. This was done in treatment-naive patients who are having advanced ovarian cancers. It included high-risk patients, either stage 3 suboptimal debulk, stage 4 patients, randomized into 1:1:1 fashion into 3 arms. The one arm included only placebo concurrent with chemotherapy and as a maintenance. Arm 2 included bevacizumab as a concurrent with chemotherapy and placebo in the maintenance. Arm 3 is of interest, which had concurrent as well as the maintenance bevacizumab. And the primary endpoint of the study was PFS, and secondary endpoint was overall survival. This is the final overall survival of this randomized clinical trial data, which was published in 2019. And this is after a median follow-up of 100 months. As we can see, relative to control, the bevacizumab concurrent has shown no improvement in the overall survival, either in the final protocol-specific overall survival or disease-specific survival. Even censoring for those patients who have received second-line bevacizumab or who has crossed over to receive bevacizumab from the placebo arm had not shown any improvement in the overall survival. So there was no overall survival benefit even in those patients who have been censored for bevacizumab crossover as well. So even in the stage 3 and stage 4, in stage 3, there was no improvement in overall survival, and in stage 4, if you remember, there were only performance status and debulking status. But this again, stage 4, patients had shown some amount of improvement in the overall survival, 42.8 months versus 32.6 months, a modest improvement of 10.2 months in this high risk population. And there was a biomarker-based exploratory analysis as well that also showed that irrespective of the BRCA1, BRCA2, HRR status, or CD131, CD31 expression, these are not predictive of bevacizumab activity. So there was no initial cost-effective analysis which was done in the GOG21 trial, and subsequent cost modeling has shown that addition of bevacizumab to standard chemotherapy was not shown to be favorable. So this is the ICON 7 study schema, again very similar to that of the GOG218. It included those patients who are high risk of progression. These are surgically debulked, histologically confirmed ovarian cancer patients who are randomized to either placebo plus paclicarbo or placebo plus bevacizumab concurrent, paclicarbo plus bevacizumab concurrent followed by bevacizumab maintenance. The dosing schedule is a bit different. It is 7.5 mg per kg and it is given for 18 cycles. So this is the updated analysis which was published in 2015. We can see that there was no survival benefit of bevacizumab which was recorded compared to that of the control group, 44.6 months versus 45.5 months. And in an exploratory analysis of a predefined subgroup of high-risk patients, who are these high-risk patients? These are the patients who are having stage 4 disease, inoperable stage 3 disease, or those patients who are suboptimal debulked stage 3 disease. As you can see, in those patients, there appears to be some amount of survival benefit, 34.5 months versus 39.3 months, very bonus survival benefit in favor of using bevacizumab maintenance. Apart from that, in the intention treat population, in the study population as a whole, the bevacizumab addition to the platinum-based chemotherapy did not increase overall survival. So coming to the PARP inhibitors maintenance therapy, these are the drugs that actually inhibit the poly-ADP ribose polymerase, which is useful for the single-strand DNA break repair. In those patients who are having HR deficiency status, these inhibitors can result in synthetic lethality. The use of maintenance therapy comes from these 5 clinical trials: SOLO-1, POLO-1, PRIMA, VELIA, and ATHENA. As of now, we have no access to veliparib as well as niraparib. So I'm going to limit my discussion to SOLO-1, POLO-1, and ATHENA clinical trials. As you can see, the evolution of the ovarian cancer, now it is not a single disease. It has evolved into some multiple subtypes, grossly divided into HR deficient and HR proficient. HR deficient also includes those patients who are germline BRCA mutant, either BRCA1, BRCA2, or somatic BRCA mutant, which is basically, can be tested in the tumor tissue. So about 25% of these patients who are HR deficient can be expected to have the BRCA mutation, either germline or in somatic, and rest of the 25% of patients have the mutations in several other genes which are responsible for the DNA repair. So this is the testing for HR status, which is shown in the POLO-1 and PRIMA clinical trial. This is determined by Myriad, My Choice, companion diagnostic technique. In that testing, HR deficiency was defined as both BRCA mutation, either somatic or germline, in associated with the genomic instability score, which can be calculated from the 3 genomic instability parameters, which are loss of heterogeneity, telomeric allelic imbalance, large-scale state transitions. This will give you a cumulative score which could be more than 42. Then the patient can be diagnosed as HR deficient. So this is the very interesting SOLO-1 clinical trial. This was the olaparib versus placebo as a frontline maintenance in patients who are having BRCA mutation. This is a randomized double-blind placebo-controlled multi-center phase 3 trial that randomized patient in a 2:1 fashion to either placebo or olaparib. These patients have undergone optimal cytoreductive surgery and have at least complete response or partial response to initial platinum-based chemotherapy. Most of these patients are having germline mutations, and basically these patients went on to receive olaparib for nearly 2 years, and the primary endpoint was PFS. So this was the SOLO-1 PFS, updated PFS at 5 years. As you can see, at different levels of time frames, significant improvement in the PFS. At the time of 5 years, the PFS was 56 months versus 13.8 months, and a whooping 0.33 hazard ratio, which was significantly statistically significant. Again, the difference was nearly 42 months. So going on to the POLO-1 clinical trial, this is again a very similar study design, but the study interventions include olaparib in combination with bevacizumab versus bevacizumab plus placebo, and bevacizumab was given at 15 mg per kg for almost 15 months. Again, olaparib was given for 2 years. Primary endpoint was again PFS. It also included patients who are having who are not selected for the BRCA mutation status, but had a HR deficiency which was tested by Myriad Diagnostics. So all the patients in the POLA1 clinical trial had the HRD deficiency tested using the myriad my choice testing. As you can see, nearly 48% of the patients had HR deficiency, 39% having BRCA mutation, and another 34% having non-BRCA mutant HR deficiency. So this is the POLA1 clinical trial, PFS data as by the HRD status. If you look at HRD positive, which includes even tumor BRCA mutation positive patients, you can see 37.2 months versus 17.7, hazard ratio 0.33. In those patients who are HR deficient but not BRCA mutant, you can see that HR ratios drops down to 0.43. But in those patients who are having no HR deficiency and are also negative for BRCA mutation, we can see the hazard ratios are only 0.92, not crossing, and also crossing the median. And the absolute numbers are also absolutely bang on at 16 months. So coming to the PRIMA clinical trial, this drug is not available with us. This is the niraparib data. Basically, these patients were using niraparib as a maintenance post-platinum-based combination chemotherapy. Again, we can see the PFS of patients based upon the HR deficiency and HR proficiency status. Unlike to the POLA1 clinical trial, you can see that even in HR proficient patients, the hazard ratio was 0.68 and it was not crossing the unity, suggesting that niraparib provided clinical benefit even in those patients who are HR deficient and also as who are HR proficient. Coming to the latest clinical trial, which is the Athena mono study design. This again had a very similar study population. These are the patients who had optimal cytoreduction and also received 8 cycles of platinum-based chemotherapy, up to 8 cycles of platinum-based chemotherapy, and had at least partial response to that. And these patients were randomized in 4 groups. The one group had only placebo, the other group had either rucaparib or nivolumab. The arm A had both rucaparib and nivolumab. The present study analysis, which is limited to the Athena mono, was testing arm B versus arm D, which is rucaparib plus placebo versus 2 placebos. The primary endpoint of the study was PFS. As you can see, the investigator assessed PFS was significantly better with rucaparib at 28.7 months compared to 11.3 months in the placebo, hazard ratio 0.47. Rucaparib maintenance significantly improved PFS, and it was similarly seen in the investigator assessed as well as the blinded independent committee review as well. So this is the intention to treat population, even in those patients who are having who are unselected for the BRCA mutation status or HRD status, appear to be benefiting with the addition of rucaparib at 20.2 months versus 9.2 months. But I think most of this benefit was driven by those patients who are either BRCA mutant or HR deficient. As we can see in those patients who are HR deficient negative as well as BRCA mutation negative, we can see that the numbers were 12.1 months versus 9.1 months, an absolute difference of only 3 months, but this was statistically significant. 0.65 is the hazard ratio. So we can see the first plot looking at the various subgroups. Most of the groups have benefited with the use of rucaparib. As you can see, the best group is the BRCA mutation group. The subsequent group is the HR deficient group, and the last group is the HR deficient as well as the HR deficient negative as well as BRCA wild type group. So this is the, I will conclude my brief discussion on the maintenance with the meta-analysis from Dr. Seema Gulia from Tata Memorial. We can see they have done the meta-analysis based upon the maintenance therapy with PARP inhibitors in newly diagnosed advanced epithelial ovarian cancer. This was manually extracted individual patient data for PFS from published survival curves of RCTs that compared PARP inhibitors versus placebo as a frontline maintenance strategy. And they have done it for whole study population as well as for the subgroups. The primary outcome was PFS in the combined population as well as in the subgroups. So in the in the individual patient data analysis of combined population from the 3 RCTs, nearly about, these are the 3 RCTs which include basically POLA1, PRIMA, as well as the VELIA clinical trials. As you can see, the PFS was significantly longer in the PARP inhibitors versus placebo, 20.4 months versus 15 months, respectively, the hazard ratio of 0.61, which was statistically significant. When they compared for the subgroup analysis, they included the 4 eligible RCTs, and they have shown that median PFS was significantly longer with PARP inhibitors versus placebo in the BRCA mutant, as well as in the HR deficient, including BRCA mutant, HR deficient without BRCA mutation, but not in those patients who are HRD negative. So again, the trial level, trial level meta-analysis were concurrent with the individual patient data meta-analysis in whole population as well as the subgroup population. So these are the curves for the 3 clinical trials that have the entire population. We can see the addition of PARP inhibitors significantly improved the PFS. So this is the meta-analysis data for the patients who are HR deficient with BRCA mutation included, HR deficient with BRCA mutation excluded. Again, you can see that the group that doesn't have the HRD mutation positivity did not benefit with the use of PARP inhibitors. So in conclusion, maintenance therapy in frontline treatment after response to initial chemotherapy, initial treatment with chemotherapy, definitely we should offer olaparib for those patients who are tumor BRCA mutation positive. We can consider offering olaparib in combination with bevacizumab to patients with tumor BRCA mutations and or with the genomic instability if they have responded to bevacizumab plus chemotherapy. Data does support the maintenance PARP inhibition with niraparib and rucaparib to all patients irrespective of the BRCA mutation status or the HRD status, but we are awaiting full publications. The reasonable alternatives include observation or use of bevacizumab maintenance. With that, I would like to conclude and thank the organizers for this opportunity. Thank you very much.
Thank you, Dr. Rakesh. It was a super fast presentation, but very informative. So thank you very much. And now I would invite Dr. Akhil Kapoor.